On behalf of my co-chair, Professor Sanjay Bhagani from the Royal Free Hospital in the United Kingdom, my name is Jonathan Schapiro from Sheba Medical Center in Israel, and we are delighted to welcome you to our fourth session on the COVID vaccine program. Next slide, please. We have a delightful session with four speakers. We will start with Miriam Sturkenboom on optimizing safety surveillance for COVID-19 vaccines, followed by Rebecca Weintraub on how to vaccinate first to get maximal public health benefit out of the vaccinations, followed by Bisola Ojikutu on combating COVID-19 vaccine misinformation and disinformation, a clinician's perspective. And finally, Elliot Raizes from the CDC on vaccine preparedness, vaccine hesitancy, and adverse event surveillance from a CDC perspective. We'll be finishing today's program with a live Q&A, and we would be delighted if folks could submit their questions on the chat. We have about half an hour, and we would like to address as many of these as possible, so please feel free to submit them. With that, let me introduce our first speaker. Miriam Sturkenboom is a pharmacoepidemiologist. She is a professor in observational data analysis at the Global Health Group at the Julius Center at Utrecht University Medical Center in the Netherlands. She is past president of the International Society for Pharmacoepidemiology and serves as an expert to organizations including the EMA, FDA, and WHO. Her research interests focus on transforming real-world data into real-world evidence on drug use, effectiveness, and safety in vulnerable populations. She was coordinator of the IMA-funded Advanced Public-Private Collaboration aiming to establish a tested system for monitoring of benefits and risks of vaccine. Professor Sturkenboom is a member of the WHO Global Advisory Committee for Safety Vaccine. She has supervised more than 50 PhD students and has more than 400 peer-reviewed papers in the area of pharmacovigilance, pharmacoepidemiology, and medical informatics. We are honored to have her speaking to us on optimizing safety surveillance for COVID-19 vaccines. Miriam.
Good morning, afternoon, or evening. I'm very grateful to have the opportunity to present the optimization of safety surveillance of COVID-19 vaccines. So what is required for an adequate safety surveillance of COVID-19 vaccines, which of course is crucial? So on the left-hand side, what we see, we have routine measures, which is done for every medicine that comes to the market. So first of all, data from clinical trials from the pre-licensure phase. And in COVID-19, these are, they are published actually in the risk management plans, which are also publicly available. But then we have an important routine measure, which is spontaneous reporting. And this is done through spontaneous reporting databases, which exist in the US, such as the VAERS database, in Europe, the Eurovigilance database, and then there's also a global database, VG-based, that is actually a WHO-led initiative. On the right-hand side, we see additional monitoring opportunities, and these are actually being put in place for the COVID-19. And that is to do active surveillance of, for signal detection, to do a rapid assessment and to have signal evaluation capacity. So today we will look at all of these actually in more detail. So on this slide, we see actually the program for safety surveillance of the COVID-19 vaccine. So in the arrow you see above the start of the vaccination, so that's the licensure of the vaccine. And on the left-hand side of that, we see a box which is in red, and these are actually the activities that could be done prior to licensure. So first of all, the trial data, which we have all seen, but other activities that were conducted were actually to prepare a list of adverse events of special interest, ASI, and these are events that not necessarily occur after vaccination, but for which you want to be prepared, that if they occur, they would actually be able to derail a vaccination campaign. So you do want to have the definitions ready, and you do want to know how often these events occur in the absence of the vaccine, so that you're able to calculate immediately whether they occur more frequently once the vaccine is on the market. And we'll look at that. Now, after the start of the vaccination campaign, what needs to be put in place immediately is the spontaneous reporting. And what has been put in place specifically for the COVID-19 vaccines is the cohort event monitoring. Then later on, once data is starting to accumulate in the healthcare system, you also want to utilize large linked healthcare data, which are actually collected just for healthcare purposes, but can be reutilized to monitor safety. And you want to start using those data sources also to complement signal detection, but also to be able to do a rapid assessment of the incidence rates following vaccinations and to conduct signal evaluation. Now, how was this prepared in Europe? And of course, we also have programs in other parts of the world, but I saw that my CDC colleague will be talking about this in more detail, so I'm focusing on Europe. So EMA makes all the trial data available in the risk management plan, which is actually usually is not publicly available, but now is publicly available, so anyone can find that. And it funded a project, the Access project, which created a list of ASI. It created the definitions for those, as well as the background rates. And we'll look at some examples later on. What EMA has also in place, and that's part of their existing capacity, is the Eurovigilance system. And it funded particularly or for COVID-19, the early COVID vaccine monitor project, which is conducting cohort event monitoring and the monitoring through large linked data sources. If needed and the system needs to be scaled up, there is also the European Network of Centers for Pharmacoepidemiology and Pharmacovigilance, which can support signal evaluation if needed. And the European Medicines Agency does this through tendering of specific projects according to European rules. Now let's look a little bit more detail to this Access project. What it did, it actually listed 27 ASIs. We'll look at that in a later slide. It prepared all the codes that you need to identify those events across different vocabularies, such as ICD-9 and 10, READ, ICPC, and it had the definitions. And this was already delivered in September 2020. The project also created 8 template protocols to assess coverage, effectiveness, and safety of the COVID-19 vaccines. And it used different types of data collection, and these protocols are ready to be implemented if needed, so that all the scientific discussions around them and the stakeholder input on them has already happened, and they are just ready to go if it's needed. Then what the Access project also did already prior to the is to create the background rates of the ASI, and we'll look at an example later. In this slide, you see an overview of the adverse events of special interest that have been defined. So a long list of events that some of which we know may occur after other vaccines, so they are listed here. Narcolepsy, because one of the upcoming vaccines may have the adjuvant AS03, which has been associated with narcolepsy in the H1N1 pandemic. And then death, sudden death, and COVID-19, and death was added, is on this list because it's clearly able to derail a vaccination campaign if that would happen. So you need to be ready to know that. And then in the project, the Access project, there were also maternal neonatal outcomes for which you want to be ready if pregnant women will be vaccinated. You also want to know, whether events occur. So what is being done for each of these ASIs in the Access project is that actually the background rates are being calculated, and a background rate is an incidence of an event. So how often does an event occur in the absence of the vaccine? And this, of course, could very nicely be done prior to the launch. So this has been calculated on the basis of various data sources in Europe in 7 countries. utilizing existing healthcare data. And what you see here is a graphic where on the x-axis you see the incidence rate per 100,000. And this is the event death. So this was done for each of the other ASI, but now we look at death. And here you see per database. So ARS here is a database in Tuscany, and you see the death rates by age. And you see very nicely in this graphic that the incidence of death really increases with increasing age, as we expected. And this is a similar pattern across all of the countries, of course. But here we have the exact number. So how often, what is the exact mortality rate in that specific age category? Now, it's very important to know that because, for example, there was a signal very rapidly after the start of vaccination in Norway, where 23 deaths were reported in frail elderly. And this caused quite a concern initially. But then, because the Norwegians could rapidly estimate that these old people in these nursing homes, on average, they would expect 300 to 400 patients to die in these facilities. The 23 was much less than the 300 to 400 you would actually expect. So basically, the background rate, which is the mortality rate, was being utilized to calculate how many patients you would actually expect to die. And especially once you start vaccinating very old people that have multiple morbidities and have higher rates of certain events, it's important that you can put the events into a context so that you know what you would expect, so that you can always rapidly assess whether the observed is more than the expected. So because of these calculations, the Norwegian regulators were able to reassure the public. And it was necessary according to their lessons learned, and this is a screenshot from a presentation they made to the WHO Euro meeting, to really, because very quickly this signal was out in the media, and they needed to really quickly respond and work together also with international organizations to get this message out. So that's how to do, if there is a signal from spontaneous monitoring, how you can utilize the background rates to actually interpret them. Now here we look at the next step, that's the cohort event monitoring, which has been put in place specifically also for the COVID-19 vaccines. It's active surveillance, so you really want people to actively report, and the way this is being undertaken is that people that are vaccinated are invited to participate in this cohort event monitoring. They can register online, fill out a baseline questionnaire, they get their vaccine, and then periodically, after 1 week, 3 weeks, 6 weeks, 8 weeks, and 3 months, they get a questionnaire that they can fill out. And the purpose here is to monitor the occurrence of adverse events. So you can actually calculate how frequently they occur. Such a system is being put in place, was put in place in the US, and that's the VSafe system. It's being put in place in Germany. The SafeVac system is being put in place in the Netherlands and other countries as part of the early COVID vaccine monitor project. So they're all monitoring the occurrence of the of adverse events following COVID-19 vaccination. What can you expect from such a system? And this is data that was presented by Tom Shimakaburo from the USA CDC. Basically, you can count for each of the vaccines. Here is Pfizer, BioNTech, dose 1, dose 2, Moderna, dose 1, the frequency of local and systemic reactions in the first week. And so you see here that reactogenicity or reactogenic reactions, the local reactions and more systemic reactions that we were expecting based on the clinical trial data, do occur also, in real life, very frequently actually. So pain, dose 1, 67%, 74% after dose 2. Moderna dose 1 very similar to the FIDSA vaccine dose 1. So quite, we can see that the vaccine is reactogenic, that the system works, it's picking up these events actually. And so this is how safety can be monitored using these active surveillance systems. So basically a cohort of vaccinated people is being followed to monitor systematically what is happening. So all these systems that I was talking about, so the spontaneous reporting systems, the cohort event monitoring systems have been put in place by regulators or public health organizations in many parts of the world. But there's also the need for vaccine manufacturers to do additional monitoring studies, and the ones that they are planning, you can actually see in the risk management plans. They show all the planned studies. And this is just a screenshot from the Moderna risk management plan that's listed on the EMA website. So as part of their activities, they are also stating they will do post-authorization studies in the US, looking at active surveillance of signal refinement and self-controlled risk interval studies. They have planned a similar study in the EU. So to conduct post-authorization safety surveillance studies using secondary health data to monitor real-world safety of their vaccine. Now, it's not just Moderna that needs to do it. Each of the manufacturers will get the requirement to do additional studies to address questions that are still there, or identified risk or potential risk that have been identified upon authorization. How can this be done? So here we look at an overview of how distributed analytics have been set up utilizing electronic healthcare data. So in many organizations have access to electronic healthcare data that is population-based. So this is an overview of the Sentinel system that is running already more than 10 years. So there are different data partners. And here it's a graphic of 17 data partners across the US. They put their data into a common data model, so it's the same structure of the data. Then there is an operating center that can send a script to the data partners. They run it and they return the results to the operation center that can then pull it and send it to FDA or to anybody who has contracted with them. A similar system, different scheme in Europe through the Vaccine Monitoring Collaboration for Europe. All type of different data sources that reside in different places can participate across different countries. The data stay local. They just are being reformatted into a same structure. Then there is a step of semantic harmonization. A script is being launched, so the analysis done, and then the results of that analysis is being shared on a remote environment where data can be pulled. So all of these systems are operational. They are existing also for the Vaccine Safety Data Link, for the BEST initiative in the USA, in C-Notes in Canada, and in Europe. And they can be used, these infrastructures can be used both for public as well as privately funded research. Then what is needed for the analysis of such large linked databases, of course, protocols and methods readiness. In Europe, these template protocols are ready, as I explained before. It's important, that protocols for each of such designs is ready, and depending on the type of event that is coming up as a safety concern, you would need to choose the right design, but the template protocols are ready to implement those. So what we see in terms of readiness, at least in the higher income settings, is that there is data readiness, both in terms of passive surveillance, active surveillance through cohort event monitoring, but also large linked databases that are ready. People are ready actually to work with each of those data, and the methods have been defined and gone through stakeholder input. So all of that is ready, but we know from the H1N1 pandemic, when we were also ready to look at certain events, but then that narcolepsy popped up as an unexpected safety concern. And what really was important at that moment in time is that there was collaboration, and not just national collaboration, but also very much international collaboration. So as part of that preparedness, the vaccine monitoring collaboration for Europe was being set up. So an organization that allows collaboration across multiple independent organizations in Europe to address vaccine studies, post-marketing. And the same is done also for the Global Vaccine Data Network, which is doing this distributed analytics on the basis of data on a global level. So utilizing both Sentinel, VSD, VAC4U data, and then other continents as well. It's very important to have this readiness and to be able to work together and to respond very rapidly when safety concerns occur. Thank you very much.
Thank you very much, Dr. Sturkenboom, for a really comprehensive overview of safety surveillance and preparedness for this. So let's move on to our next talk, and I have great pleasure in introducing Dr. Rebecca Weintraub from the Ariadne labs at the Brigham and Women's Hospital in Boston. So Rebecca is an assistant professor in global health and social medicine at Harvard Medical School and an associate physician at the Division of Global Health Equity at Brigham and Women's Hospital and a practicing internist. Her research interests are centered around implementation bottlenecks in healthcare delivery and equipping frontline providers with vital evidence in decision-making. She is a young global leader as awarded by the World Economic Forum and has led the Ariadne Labs vaccine delivery workstream of the COVID-19 response. So her talks on who to vaccinate first for maximal public health benefit out of vaccinations. So thank you very much, Rebecca.
Many thanks for having me at the COVID-19 Vaccine Development and Implementation Workshop. I'll be presenting on maximizing the impact of COVID-19 vaccination with speed, scale, and equity. My takeaways today are the following. For current and future COVID-19 vaccine rollouts, robust delivery strategies are essential to manage the initial scarcity and adapt to the dynamic demand for COVID-19 vaccines. In order to maximize the public health benefit for vaccines, we must leverage the evidence base on how to design delivery channels to vaccinate with speed, scale, and equity. Vaccination. We have two primary goals. Number one, for direct protection. How do we vaccinate those most likely to die? And the second, herd immunity. Vaccinate as many people as possible, especially high transmitters, to slow transmission and protect even the unvaccinated. Now we need the systems to set up and maximize our chances of meeting these goals and adapt to the situations of supply and demand. Early in the fall, we began discussing a framework that was necessary for vaccination in the midst of a pandemic. This requires setting up delivery infrastructure for the allocation, distribution, getting the right vaccine to the right people at the right place, verification, ensuring proper distribution and tracking progress, alongside demand, generating and addressing hesitancy, tailoring engagement, and communicating the power of the vaccine today. Now we're facing a dynamic market. We are in this first phase of low supply and high demand, but all states and all nations are facing, in many ways, a bullwhip effect, unsure and uncertain of the supply ahead. Given the scarcity, we look to modeling to help us consider the impact of vaccine prioritization and strategies on both mortality and infection. This study done by colleagues at University of Boulder and the Harvard School of Public Health reminds us of the impact of prioritization. For example, should we consider mortality versus infection? And this team looked at using an SEIR model, susceptible, exposed, infectious, and removed model, to ask targeted questions. Their conclusions: vaccinating older adults prevents most deaths. Unfortunately, we don't know everything about the vaccine portfolio today and its ability to decrease transmission. Otherwise, it would be wise to prioritize vaccinating the transmitters. But under all the uncertainties as of today, prioritizing the elderly is the maximum way to, the most important way to minimize mortality. And another uncertainty ahead is actually the definition of the essential workers, very much a prioritization for many nations. This is actually figuring out who are actually within these transmitter groups and their competing interests within these priority groups. The definitions matter here. The current definition, for example, of essential workers by the Center for Disease Control's compromises nearly 70% of the American workforce, sweeping in not only grocery store clerks and emergency responders, but tugboat operators, exterminators, and nuclear energy workers. Each state now has interpreted this differently, leading to different essential workers receiving the vaccine in the prioritization ahead. In addition, we're seeing the complexity of the flow of information regarding COVID-19 vaccine rollout. For example, here's a map of the flow of data across the federal entities for the United States vaccine rollout. Operation Warp Speed subcontracted out to several entities, including Tiberius, for example, to manage this complex data map. Unfortunately, all these data sources are not available, nor the means in which these algorithms were determined, leading to complexity for the states. As of today, the states will only begin receiving a week's notice, and next week, 3 weeks' notice of the vaccines will be deployed within their states. In addition, the United States has actually faced a patchwork of data available from the websites of public health entities. For example, you can see the patchwork ahead across the 37 states that have some information, and we currently have several states that have no information for public consumption. This impedes not only planning, but obviously monitoring and accountability during the COVID-19 vaccine rollout. An example of a positive outlier here is Tennessee. Here's their COVID-19 vaccine dashboard, quite complete, where they've been able to identify where the doses are going. For example, 85% of the vaccine doses are distributed across the state, how they decided to distribute 10% to areas that were high on the CDC's social vulnerability index. And as a result, Tennessee has decided to send extra vaccine doses beyond standard to 35 of the 90 counties hardest hit by the virus. Among them is Hayward, a county whose population is about 51% African-American, and where the coronavirus mortality rate is more than double than the state average. Dr. Fiskus, who leads this effort, said, "We want to give more vaccines to that county to be able to vaccinate the population faster because the people are dying." Today, we're at a critical moment. Time and vaccine supply are limited. The longer it takes to vaccinate and stop the spread of COVID-19, the more escape variants we will see, and the longer this pandemic will rage on. We also know there's a threat of slow vaccination programs. The longer it takes to vaccinate and stop the spread of COVID-19, the more escape variants. And not only could the variants like these short circuit the immunity of those who've been affected by early coronavirus strains, they could also reverse our progress towards herd immunity, requiring people who've been vaccinated to get boosters in the future. This critical moment is complicated by the portfolio and the opportunity ahead as the vaccine portfolio advances. Modeling has been done to remind us that implementation is essential. How we actually vaccinate is as important as the efficacy of each vaccine within the portfolio, so that even vaccines with modest efficacy can still result in large reduction in both COVID-19 infections and death if they're swiftly delivered to a large percentage of the population. Here's a study done by colleagues in the United States, including Rochelle Walensky, the current head of the CDC, showing the effectiveness of COVID-19 vaccine will be shaped by how quickly we get it out to the public. Now we're at this critical juncture where there's been a tremendous investment done to provide vaccines on site at health systems, at long-term care facilities. Currently this week, the United States is deploying the COVID-19 vaccine within retail pharmacy and opening stadiums across the United States to get shots in arms. At the same point, we need to prepare last mile delivery and improve the readiness of the following practices: primary care, mobile clinics, employer-based clinics, federally qualified health centers, and community-based organizations to reach some of our most vulnerable populations. These populations include the populations that are saying, I will wait and see if my community will respond to vaccination programs, those who've been isolated, homeless, and rural populations. And this has been true for previous vaccine programs. We need to bring the vaccine to the people and meet them where they are. Here on this map, you can see the proportion of United States residents who are either within 5 miles of a pharmacy, a convention center, or sports revenue. More needs to be done to reach these populations without convenient access to the vaccine today. In addition, we need to understand the dynamic nature of demand. The polling continues to shift and change as supply becomes more available. As of today, 31% of Americans say when an FDA-approved vaccine for COVID-19 is available, they would wait to see how it works for others. We'll continue to monitor this polling data as we plan for future delivery channels. In addition, 8 in 10 Americans say they'll wait for their healthcare provider and seek out their healthcare provider's advice whether to get vaccinated. So once again, the trust quotient is sitting with the nurse, the primary care provider, the person who's already established a relationship with many of our most vulnerable patients. This data has been reinforced by additional polling here, where you can see this is trust versus reach. And it's quite clear your healthcare provider, your primary provider, has a high trust and reach across communities. So to share a bit of hope and optimism, it has been quite a heterogeneous vaccine rollout in the United States, but we see glimmers of hope as public leaders have been able to design delivery channels for both speed, scale, and equity. For example, in West Virginia, the state has been using geocoding technology to help identify where people are and who needs to be vaccinated. They've created vaccine hubs within convenient driving distances and radiuses for a rural community. And they've opened up a community vaccination clinic in all counties across the state. Connecticut, for example, created a just-in-time inventory system to think through where will the unused doses of vaccine be at the end of the day and how to transfer them to those who need the vaccine. They've also been able to expand the pool of vaccinators to include EMTs, veterinarians, podiatrists, dental workers to get more shots in arms. And a tremendous example from the state of Kentucky. Broadbent Arena opened up with the power of volunteers. Volunteers signed up for 40 hours of volunteering and then became eligible for leftover vaccine. They're now operating 7 days a week. So there's a lot of work to do considering the nature of the global pandemic to ensure the vaccine is distributed both with equity and by the evidence base. And many of us are following how the vaccines are being procured. If you see this circle ahead, there's quite a complex dynamic happening here between multilateral, contracting, procuring by nation states, and COVAX, which is representing 98 low and middle income countries looking to procure vaccines for their nations. It's also been modeled that we need to ensure this is done with cooperation. And a group at Northeastern did a phenomenal study to show the difference between an uncooperative vaccine scenario with a vaccine that has 80% vaccine efficacy to a cooperative vaccination scenario, even with a lower vaccine efficacy. And you can see the light blue and the yellow bars. If we actually cooperate, we'll avert fewer deaths and end this pandemic faster. So to conclude, many of us see the promise and the power of the vaccine portfolio, not only for this pandemic, but historically from previous pandemics. But the work ahead now is to design the delivery systems with scenario planning to ensure they are scaled and providing the vaccine with equity. And this week in the New England Journal, many of our leaders reminded us that remarkable progress has been made using vaccines. The future holds great promise for vaccine-needing control of global pathogens, but providing affordable access to effective vaccine for everyone could benefit from them remains an important challenge ahead. Looking forward to the discussion. Many thanks.
Thank you, Rebecca. That was a complete tour de force, and thank you very much. So this brings us naturally on to our next speaker. So it takes me great pleasure to introduce Dr. Bisola Ojikutu, also from the Brigham and Women's Hospital and Howard Medical School. Bisola is an infectious diseases specialist and an assistant professor of global and social medicine at Howard Medical School and an associate physician within the Division of Global Health Equity at Brigham and Women's Hospital, and a faculty member of infectious diseases divisions, both at Brigham and Women's Hospital and Mass General. Her research interests are focused around structural factors and norms and beliefs on infectious diseases transmission and prevention, and particularly for HIV and COVID-19. She's had a more recent focus on increasing participation of racially and ethnically diverse populations in COVID-19 research and in promoting vaccine uptake. And so she would be a natural speaker for this, which is combating COVID-19 vaccine misinformation and disinformation, a clinician's perspective. So thank you, Bisola.
Hello, and thank you for joining me today. My work prior to COVID-19 focused on HIV and overcoming challenges to the engagement of patients in prevention, care, and treatment, including research to better understand medical mistrust as a determinant of suboptimal uptake of biomedical HIV prevention strategies. Today, I'm going to talk about combating COVID-19 vaccine misinformation, disinformation, and mistrust from my own clinical and research perspective. I have no disclosures. I will start by defining misinformation, disinformation, and mistrust and describing their origins, then turn to their impact within the COVID-19 pandemic with a specific focus on COVID-19 vaccines. Then I would like to offer some suggestions that in my clinical experience and in the experience of others might be useful. Let's start with some definitions. Misinformation is what it sounds like. It's false or incorrect information that is not intentionally meant to mislead anyone. Conversely, disinformation is strategically and deliberately spread false information, which is created to mislead. The difference, in general, is the intent of the information. Both have spread rapidly during the COVID-19 pandemic, secondary to the widespread use of social media. Understanding the origins of misinformation, disinformation, as well as mistrust, which I'll turn to next, is critical to developing messaging and appropriate responses. The spread of misinformation may arise from the need to understand a new phenomenon where an evidence-based understanding has not already been established, like during the current pandemic with a new virus. The spread of misinformation and disinformation in the setting of an emergency also evolved from a need that we all often have to cope with anxiety and fear when faced with unknowns. Interestingly, sometimes quote-unquote conspiracy theories are viewed as a form of disinformation, but oftentimes they're not intended to mislead, but to provide explanation where there is none. The spread of misinformation and disinformation occurs more frequently when there's inadequate, inconsistent, or non-evidence-based responses from leadership in the setting of crisis, and can be very powerful as a component of an adverse political agenda. Racism and xenophobia may also lead to disinformation, as we have noted during the pandemic, unfortunately. For example, in regards to the origins of SARS-CoV-2. Lastly, anti-vaccination movements have existed throughout the world for centuries. The most notable example relates to measles, mumps, and rubella vaccination, and its now debunked link to autism. Whether the origins of anti-vax movements are philosophical, political, or spiritual, they have promoted both misinformation and disinformation to support their cause. What about mistrust? Mistrust is the absence of trust that providers, organizations, researchers, or others genuinely care for patients' interests, are honest and transparent. Mistrust is rooted in the lack of trustworthiness of institutions and systems. Mistrust promotes the spread of misinformation and disinformation, and vice versa. Mistrust and misinformation may be able to be addressed, and I'm going to offer some strategies during this talk. Disinformation, because it oftentimes derives from sources that are deliberately established to spread false information, is actually very challenging to combat. Though mistrust intersects with and may promote the spread of misinformation and disinformation, we need to understand that its origins are distinct. Medical and research mistrust are well documented, particularly among Black individuals in the United States, but also within other populations globally. The reason that medical mistrust is so prevalent among the Black population in the United States is because of historical and contemporary structural racism. Black individuals, as well as Latinx and Indigenous populations, have limited access to healthcare, more illness, worse outcomes, and experience more premature deaths than their white counterparts in the United States. These disparities have existed for many years. Mistrust is believed to be a rational and normal response to persistent adverse circumstances and a result of ongoing trauma and marginalization. Mistrust is certainly not solely a US-based phenomenon. Denial of HIV as the cause of AIDS and efforts to refute the efficacy of antiretroviral therapy or HIV treatment may partially be based in mistrust of science originating in the Western world. These beliefs intersect with and overlap with quote-unquote HIV conspiracy theories. Denialist beliefs gained sustained momentum in the HIV epidemic in sub-Saharan Africa, specifically in South Africa, but other countries too, not only because of charismatic leadership promoting these beliefs, but also because people were marginalized, had limited access to resources, and were vulnerable. Similar denialist beliefs and conspiracy theories regarding HIV have been noted in the United States and in other countries, particularly within communities of color. These beliefs are still quite prominent. In 2002, one of my colleagues conducted a nationally representative survey of Black individuals living in the United States, and they found a very high prevalence of HIV-related mistrust. That's another term for HIV conspiracy theories. We repeat the survey more than 10 years later, and these beliefs are still prevalent. For example, half of all respondents at both time points believe that HIV is a man-made virus, and half at both time points also believe that there is a cure for HIV and that the government is withholding it from the poor. Turning back to COVID-19 vaccines, what types of misinformation and disinformation beliefs are common? There are groups dedicated to quantifying the frequency of myths related to COVID-19. Here are the top 5 reported by one source. These are in order of frequency. Number 1, mRNA from the vaccines can alter human DNA. Number 2, vaccines contain microchip surveillance devices. Number 3, COVID-19 vaccines cause infertility. Number 4, the vaccines developed by Oxford University will turn people into monkeys. And number 5, COVID-19 vaccines contain aborted human fetal tissue. All of these beliefs are described as myths. Some are clearly misinformation, but all 5 have been strategically disseminated by groups and individuals with the intent to mislead online. These beliefs may impact willingness to take the COVID-19 vaccines. These are data from a survey conducted by a polling company and published by Reuters of 19,000 individuals across 16 countries. Of note, none of the countries are in Africa. Unfortunately, I do not have detailed methodology in regards to the survey. However, we can look at this as a snapshot of what may be happening in these individual countries. These data suggest that the country with the largest population of individuals who would be unwilling to be vaccinated for COVID-19 is France, where there's a long and extensive history of vaccine skepticism and anti-vax sentiment. Turning to the US, willingness to take the COVID-19 vaccines has fluctuated over time as a response or a reflection of the political context and as new data have arisen regarding the vaccines within the last year. Overall, according to data collected after the November election in the US, approximately 60% of individuals were willing to take the COVID-19 vaccines. Black individuals reported the lowest willingness at 42%. In addition to misinformation, disinformation, and mistrust, there are also other issues to consider in regards to vaccine hesitancy, which, as defined, has 3 components. Value is whether or not someone believes that they are at risk of infection. Access, affordability, and availability also contribute to willingness to take a vaccine. And of course, as already described, trust in the effectiveness, safety, reliability, and competence of the healthcare system and the motivations of policymakers are critical determinants of vaccine hesitancy. In this survey conducted by the COVID collaboration, fewer than half of all Black and 66% of Latinx respondents were willing to take a COVID-19 vaccine. Trust in vaccine safety and efficacy were the two most important predictors of hesitancy and were extremely low amongst Black individuals, but also relatively low amongst Latinx respondents. There is good news here, though. The majority of respondents were basically taking a wait-and-see approach, essentially meaning that if all goes well, they will most likely eventually be vaccinated. From the data collected by my research team, not only do mistrust and disinformation impact vaccine uptake, they are also associated with less adherence to preventative measures such as social distancing and mask wearing and lower acceptability of COVID-19 treatment. What do we do about this? Most effective interventions to address vaccine hesitancy employ multiple strategies to address misinformation and mistrust, as you see in this figure. In the short term, providing people with clear, transparent messages that include what we do know and what we don't know about the vaccines is important. The use of trusted messengers is critical. Longer term, particularly as it relates to marginalized communities, systems and institutional change are required to address mistrust. A considerable amount of the work to address vaccine hesitancy has involved mobilizing healthcare providers as trusted messengers. According to numerous studies, healthcare providers are the most trusted source of information regarding COVID-19 vaccination. But I strongly believe that engaging peers, faith leaders, community health leadership, and other respected individuals is also important, particularly if they themselves have already been vaccinated. Engaging communities who have been marginalized in the actual process of vaccine development, whether that be decision-making, in the research, not just as clinical trial participants, but at the initiation of studies to determine the overall approach, and message formation and in message delivery is also a proven strategy to combat misinformation and promote trust. But this type of engagement will involve investment in communities that have been disenfranchised and marginalized to build capacity for community members to engage as equal partners in these efforts. In terms of disinformation, as I mentioned, it is difficult to combat. But you can report misinformation and disinformation online and therefore help stop it from spreading. In the context of a strategic partnership with the UK, the WHO has joined forces with its communications teams to raise awareness of misinformation and disinformation around COVID-19 and encourage individuals to report false or misleading content online. Here's a snapshot of links provided to report misinformation and disinformation noted in social media, and you can find these by going to the website noted at the bottom of the slide. As COVID-19 vaccines become more widely available, healthcare providers and others will be called upon to engage patients in discussions around uptake or willingness to be vaccinated. Here are some communication strategies that might be effective. In general, responding to questions, misinformation, and mistrust regarding the vaccines in an understanding manner with an empathetic tone is important to engage patients in open dialogue. Validating that mistrust and skepticism are normal is also a useful strategy. Being non-judgmental and non-confrontational, asking open-ended questions, using reflection or reflective listening skills is also appropriate. Overall, the idea is to promote conversation and open dialogue with patients. Motivational interviewing techniques provide helpful strategies. The development of open communication demonstrates that you care about patients holistically and you hear their concerns. Reflect and roll with resistance or in other words, leaving room for patients to state their concerns in their own words and reflecting their concerns back to them, is also a strategy. Don't immediately correct misinformation or disinformation. Listen first, ask questions, then provide accurate information and allow patients to make their own decisions. Lastly, a number of potential messaging themes and strategies have been suggested that should, of course, be adapted depending on the population or community or patients who you're speaking with. As mentioned, acknowledging that mistrust and skepticism and fear are normal, particularly during a pandemic involving a new virus, is a strategy that could be used. Transparency regarding the known effects of vaccination, clear communication regarding the risks and the unknowns, the role of social responsibility in vaccination, the responsibility to family and friends, reframing vaccination as a form of self-empowerment, and emphasizing choice are all messages that can be adapted depending upon the audience. In conclusion, misinformation, disinformation, and mistrust are heightened during emergencies such as the current pandemic. They have a significant impact on willingness to take the COVID-19 vaccines, and understanding their origins is useful to determine appropriate interventions. And finally, adopting an understanding, non-judgmental approach is an appropriate communication strategy to combat these ongoing concerns. I hope that this was helpful. Thank you.
And now it takes me great pleasure to introduce our last speaker for the session. So this is Dr. Elliot Raizes, who's based at the US CDC. Dr. Raizes is an infectious diseases specialist and is currently at the US CDC Division of Global HIV and AIDS. He's served on the WHO HIV guidelines committees, and he's a member of the WHO ResNet steering committee. He's also served as a co-investigator on a number of protocols related to HIV drug resistance in PEPFAR-supported countries, and he's the current co-PI for the CDC generic protocol for cross-sectional surveys for HIV drug resistance in adults and children starting and receiving antiretroviral therapy. So Dr. Raizes is going to tell us about vaccine preparedness, vaccine hesitancy, and adverse event surveillance from a CDC perspective. Thank you, Elliot.
Long before the COVID-19 vaccines were approved, CDC recognized that a critical part of increasing COVID-19 vaccine uptake will be building vaccine confidence. Thank you to the organizers for inviting me to speak to you today about our approach to this important issue. As this poll from the Kaiser Family Foundation shows, geography, race and ethnicity, political affiliation, type of employment, and other factors can affect vaccine confidence. In general, men are more likely to be hesitant, while Black and Hispanic adults are found to be more hesitant than white adults. However, after completion of the first month of vaccine rollout, we have seen overall increases in persons willing to be vaccinated. Though recent polls have shown that the number of people saying they are willing to receive the COVID-19 vaccine is increasing, there is still work to do. And there are many factors influencing people's acceptance of the vaccine. It is our job to let communities know that it is okay and valid to have questions, and especially for those communities that have been hurt by societal systems, long-standing inequities in access to health and social services, an ugly history of medical experimentation, forced sterilization, systemic racism, and recent experiences with COVID-19 have hit communities of color particularly hard, all resulting in low confidence in vaccines. We also know that undocumented people may have also be afraid to get vaccinated. The communications activities and outreach efforts we undertake related to the COVID-19 vaccine really depend on vaccine confidence. We define vaccine confidence as the trust that parents, patients, or providers have in recommended vaccines, providers who administer vaccines, and processes and policies that lead to vaccine development, licensure, manufacturing, and recommendations for use. This foundation of trust is critical. Confidence in vaccines can change depending on what is going on. For example, a person may refuse to get vaccinated, but then when they hear that millions were vaccinated safely, they may move into passive acceptance or even demand. An expert working group chaired by WHO has developed a behavioral model specific to COVID-19 vaccination uptake. The factors associated with COVID-19 vaccine uptake are what people think and feel, social processes, motivation, practical issues. Each domain can be measured to understand barriers and enablers of COVID-19 vaccine uptake. CDC's efforts to build vaccine confidence and conduct outreach are under the Vaccinate with Confidence strategy noted here. Our strategy has 3 pillars: build trust, empower healthcare personnel, including community health workers, and engage communities and individuals. In building trust, our objective is to share clear, complete, and accurate messages about COVID-19 vaccines and take visible actions to build trust in the vaccine, the vaccinator, and the system in coordination with federal, state, and local agencies and partners. We also want to promote confidence among healthcare personnel in their decision to get vaccinated and to recommend vaccinations to their patients. And we want to engage communities in a sustainable, equitable, and inclusive way, using two-way communication to listen, build trust, and increase collaboration. We have therefore engaged in a number of initiatives to achieve the goal of vaccine confidence, including instituting phone and virtual one-to-one support for state and territory immunization programs, local health departments, and immunization coalitions. We also are implementing a rapid community assessment guide using tools such as a vaccine rollout template, key informant interviews, a listening session, observation, and traditional and social media monitoring. The FACT Alliance represents a partnership initiative to bring together trusted community-based messengers to develop culturally sensitive messages and strategies to increase COVID-19 vaccine confidence and uptake among communities disproportionately affected by COVID-19 morbidity and mortality. CDC is leading the FACT Alliance to collaborate with trusted key messengers who can help bridge the gap between the government and communities of color on creating appropriate messages, materials, and promote promising solutions to build vaccine confidence. CDC funds minority-led national organizations, including minority-led professional associations. Some of these organizations will provide sub-grants to local chapters to support community-level action. We will also support our established network of funded recipients that include local health departments, community-based organizations, federally qualified health centers, all within our immunization and community health programs to focus on vaccine awareness, access, and confidence. Funding also can support national level organizations to provide support to local branches, chapters, and community-based organizations, as well as deploy vaccination educational campaigns as part of their broader communication strategies. Finally, of course, our vaccine confidence requires an ongoing safety monitoring program that I want to discuss with you today. CDC has implemented a number of models to monitor vaccine safety, including active surveillance through the use of vSafe, or the after vaccination health checker, passive surveillance through the use of the vaccine adverse event reporting system, and individual case consults through our clinical immunization safety assessment project. Data from all these systems are fed into a large linked database monitoring system. Recent data from our systems shows, of course, that we, as of earlier this week, are up to almost 45 million vaccinations having been given, at least the first dose, with about half for each of the 2 vaccines that we have available. Our data on registrations into VSafe is not quite as recent, and we are reporting pregnancies within VSafe, as you can see. And so some of the early data that was reported based on our lock point from January 14th does show that while pain continues to be something that people experience with the vaccination, whether it's the first or second dose, other symptoms such as fatigue, headache, myalgia, and chills seem to be much more common with the second dose of Pfizer compared to the first. We look forward to the next data set to be able to see whether we are seeing similar results with the second dose of the Moderna vaccine as we obtain that data this month. So I want to thank you for your interest and happy to answer any questions in the Q&A session.
So thank you very much, Elliot. That was great. I would like now to do is invite all the speakers for a roundtable discussion. We have a number of questions coming through the chat, and I'd like you all to send more questions if you have more. So let's start with sort of vaccine safety initially, Miriam. So there's a couple of questions around this. An important question is, with the reduction in winter flu in the Northern Hemisphere, will this affect the background rate of mortality in the frail and the elderly and the rate of neurological events like Bell's palsy? And how will this affect monitoring of safety data in terms of background rates?
So thank you very much for the question. So indeed, there will be less mortality due to influenza, as we expect. But what is generated usually is background rates over a longer period of time with different seasons. So if that is the case, you would be able to apply rates that come from various seasons to adjust for that. So indeed, when you do observed expected analysis or you do a signal detection, there always will need to be a margin to take care of those uncertainties that you may have. But for now, what we see is that the number of reported death, even if we have reported death, but they're far less than what you would expect in these frail elderly that live in long-term care facilities.
That's great. Thank you. I suppose, and just keeping on the safety issue, because this is a question that I get asked all the time, and we started our vaccination programs in sort of mid-December. Are there any concerns of vaccinating women who are pregnant or maybe contemplating pregnancy? And where can we find information around this? Because a lot of people are asking about this, and when will we get the data?
Yes, very good question, and indeed an important one. We know from the clinical trials that pregnant women were not included. There were a little bit more than 50 women that somehow were pregnant or inadvertently pregnant. So they are being followed up, and there seems to be no adverse event happening there. There have been reprotox studies that do not show any effect on reproductive toxicology. So what regulators usually do then is that they state that there is little evidence or there is no evidence to use it because they haven't been utilized in pregnancy. However, I think that's a very secure statement. What and that has changed in the UK, for example, where they've stated now that there's clearly no effect on seen in reproductive toxicology in the preclinical stage. So it's more assertive in that way. But the reality is that we don't have a lot of evidence during pregnancy. So it's really important to monitor that. In the US, the advice is to vaccinate. In Europe, they haven't done that. So it's just women at risk or at high risk pregnancies, or those in contact with a lot of people that may be infected that may consider vaccination, and then they're advised to vaccinate. And I think as a community, we have a duty to make sure that we do collect the information at this moment now that they are being vaccinated. So what is important is that these systems are in place to actually actively monitor the pregnancies and their outcomes.
Yeah, I mean, I think this is an important issue, and the data around the outcomes of COVID-19 in pregnant women are mixed, as you know, and so especially those that are at high risk and in professions that put them at high risk of exposure. This has certainly become a big debate. And in the UK, the advice was always risk versus benefit. And if you're a healthcare worker in the front line who's pregnant, then the benefit far outweighs the risk. I wonder if anybody else has had that same question come up in terms of pregnant women and vaccine safety, and whether this has put some people off being vaccinated, even though they're in high risk professions.
Well, I think in the field, I don't have a full oversight of what is happening in the field with those decisions that are being made, but it's clear that it's always a benefit risk assessment. And I think with the current lack of solid evidence, it's left to the physicians to support the women to make that decision. And I think that's difficult. So there is now guidance being developed. There was also a very nice paper from Diana Bianchi, actually, in JAMA this week, last week, about the need to follow pregnant women and that they should not be withheld from vaccination. And a very important message that actually we should not protect women by not participating in research. We should actually have them be protected through research. So I think it's a culture change that also needs to happen, but whatever has happened in the clinical trials around COVID-19 vaccines, where they haven't been included at this point, we need to make sure that we monitor it so that we can provide the evidence as soon as possible. And for now, I think it's up to the individual woman who is deciding for two with her physician to make that decision of what is best. And we do get evidence now that during pregnancies, there is if you get COVID, you have a little bit higher risk to have a serious or to have more serious outcomes, but the absolute risk is very low. So it's only, I think, 1.5% that gets into the ICU when you're pregnant. So that's a very low absolute risk, and that needs to be weighed against the uncertainty that we have that about the effect on pregnancies, but there's no evidence now to assume that there would be a negative effect on the pregnancy. And we have seen that also from influenza vaccines. There was no negative effect whatsoever on pregnancy outcomes. So that's the balance that needs to be weighed, actually. And at this point, I think it's because there is no solid evidence, it's up to the healthcare professional and the patient itself.
Fantastic, thank you, Miriam. So, just changing tact a little bit, Rebecca. There's a question here. It says, if we get another pandemic responsive to vaccine, how should vaccine distribution be organized, both in the US and in low middle income countries? And are there lessons to be learned already from what we've done so far?
Thank you so much, and thank you for having me today. I mean, this is, I think, the question that many folks who've worked in pandemic preparedness had asked decades ago, and created a tremendous evidence base that we had hoped would be exercised as of March of 2020. And when many folks who are part of this panel and others have kind of reminded us, this is an unfortunate pattern. When we face an emergency, people revert back to the nation state, the political borders of a nation, versus where the virus goes. How do we suppress the virus and how it's transmitting to others? And I think we've seen just tremendous leadership from public health colleagues and epidemiologists and modelers to remind us this is how we should distribute one of our arsenals, not only the vaccine, but how we think about masking and social distancing, that we're collectively working towards viral suppression. I'm somewhat optimistic, actually, because this has had such an effect on almost every human on the globe, that people will invest now in not only pandemic preparedness, but this idea of global allocation of a scarce resource. And there's just been a tremendous interdisciplinary effort to inform this moment. We may have missed some of the planning windows, but I think there's future planning windows, for example, with a one-dose vaccine ahead and others, where we can reform how we're allocating to ensure it's being evidence first.
Yeah, and you know, I suppose even in the NHS, where we have a socialized healthcare system, vaccine distribution has been difficult. It's been tremendously well organized, and you know, we've now got primary networks kind of rolling out vaccines, but it took us a long time to get here, and you know, I think this is difficult all over the world. I mean, I don't know if Elliot, Bisola, you have different experiences.
So I would just add to that, and I appreciate, you know, being a part of this discussion, that, you know, here in the U.S., I think one of the major issues and one of the buzzwords, and I say buzzword because a lot of people are using it, but it's very meaningful. It's about inequity, you know, and about the fact that you have people who are, you know, marginalized from the system, who have a history of dealing with structural racism, who may not have access to healthcare, may be undocumented, maybe, you know, lower income, Black, African-American, Latinx individuals who are not getting access to the vaccine for a variety of different reasons. I mean, we talk about these issues of low vaccine confidence, but it's also about access, affordability, acceptability. Now, affordability may not be really the issue, but it's really about, you know, accessibility. Are the vaccine sites in the locations that are near these people's communities? Is it near people? Are they aware that it's there? And do they have a seamless way of accessing it, to signing up for it? These are major barriers to actual equitable distribution of the vaccine here in the U.S. that still, you know, need to be addressed. I mean, that the data is showing that we clearly have disparities in who is actually accessing vaccination, and that isn't just about low vaccine confidence. That is about access as sort of a broader issue, and it's something that's characterized our healthcare system in many different ways. If you talk about interventions in general.
Yeah, and you know, in almost a sort of related sort of way, you know, there's questions in the chat about how are we going to get vaccine out to poorer countries, so to speak, low middle income countries. And you know, there's a question from Kenya saying, what is the point of hoarding vaccines when, you know, resource poor settings are not getting them? So what do we make of that?
I'm pleased to jump in here. I mean, I think we have to monitor this vaccine rollout, not only for the scale, but its speed and equity. And I think Bisola is making an important part, that we've thought so much about the scale of reach. For example, you know, X countries begun its rollout, or X number of doses that have been allocated, has been distributed, has been administered. But we need all three to actually use the power of the vaccine to prevent transmission to those vulnerable populations. And that planning was not done in the fall of 2020, alongside the investment in the discovery and development of the vaccine. And without that planning, without that type of design principles ahead, this is why we have this scattershot effect. This can be different. I think it's kind of the message we're trying to say. And when the vaccine's delivered in a with a hyperlocal provider to vulnerable populations, the uptake is significant. So in many ways, I think this is latent demand. We have not delivered the vaccine to the provider that you trust the most. And that has actually delayed the uptake and kind of expanded this population that is in a wait and see time period, waiting for the vaccine to come to their neighborhood.
Yes, if I may chime in there, because I think what was unfortunate, of course, with the COVID-19 vaccines, the first ones to reach authorization or to reach the market, I mean, they have this complex cold chain, needs actually, which has really jeopardized distribution, I think, or even, the ability to have it in countries that have less of those facilities. And so people were pointing towards or investing a lot on the vaccines that had less of that cold chain, which now seem to be less effective, especially against the South African virus. And so there is a chain also of events happening that doesn't make it easier for the lower middle income countries to actually get access to this.
Yeah, I mean, and that's a point well made in terms of the cold chain and access. But if I may say so, that with the Ebola vaccine, which also required the cold chain, we were able to get this into tens of thousands of people in the DRC without significant problems. I think there has been a certain amount of sort of vaccine imperialism here in terms of some of the big countries kind of buying stocks, etc. I think all of this, the equity will need to come through at some stage, and people are going to need to try and sort of make sure that, as somebody said, if you are not protected, I'm not protected. So we need to make sure that the whole world is protected. Okay, so that's a debate that will probably rage on, but let's try and answer a few specific other questions that are coming through. So, Bisola, one of the issues that's kind of even reared its ugly head here in the UK is healthcare workers being hesitant to take the vaccine, and then somebody points out that in the US it's around 26%. I have to say in our own unit it's around 40%, and there seems to be an overrepresentation of Black and minority ethnic groups in this vaccine hesitancy. What's your experience, and what can we do about this?
Right. No, I think that's a really important question. It's really a twofold concern that we have. First of all, if you look at all the data about the concept of trusted messengers, who are people really listening to? Almost all of those point to healthcare providers, who are people are responding to. These are the people who are changing people's minds in regards to their choice. This is pre-COVID. I'm not just talking about COVID vaccines. So if you have the people who are the most trusted messengers, who are they themselves skeptical, who they themselves have low confidence, then you really have a problem. So colleagues and I have colleagues at Brand. We're in a partnership right now where we've looked at this issue of low vaccine confidence, specifically amongst Black individuals. And so what we found is that if you look at healthcare providers versus non-healthcare providers or healthcare workers in general, just as a large group, what we found is that actually healthcare workers within the cohort that we looked at actually have lower vaccine confidence than other people. So that's a major problem, right? And then you have to kind of look at the root of that. And I think it's really saying something powerful, that even people who are in the system, quote unquote, still don't believe in the system that developed this vaccine, because the root of that is that they're not trusting the safety, the efficacy, and the people who actually developed it. So the pharmaceutical industry, the government, and academic institutions. So that's very concerning. So what do you do about that? I don't think that there are really great evidence-based methodologies to deal with low vaccine confidence. Honestly, I don't. I think people are coming up with things, and I think messages, clear messaging, transparency, partnerships with communities. I mean, look, there are two things. One thing that we're doing sort of short term, and I think pretty much everybody's doing this, is that we're reaching out to peers. So peer healthcare workers are saying they've been vaccinated, they're expressing their concerns, but they're also listening to people and they're sharing messages with their other healthcare workers. We'll see if that works. And I think that's a reasonable approach. But longer term, our systems need to be more trustworthy, because this is something that we're seeing globally. There's something that's not working here. The people who feel sort of outside the system are not at the table. They're not involved in the development. They're not involved in the decision making. And also what's making things worse, I think, is the way that this rollout has happened, where there are these issues of inequity that Rebecca just described, and I mentioned. When you don't see things being accessible and available to people who look like you, it makes you wonder even more what exactly is going on. So longer term, I think we need some better strategies in terms of who is actually within the business of actually developing our interventions if we really want people to consider uptake.
Yeah, absolutely. And and I think trust in the profession is hugely important here. So I'll give you an example, and this is another question that's been raised on the chat. In that in the UK, we made a decision quite early on that despite the data with the Pfizer vaccine, we were going to prolong the interval between the two doses so that we could have maximum efficacy for people that really need the vaccine. And so and this was not based on data. I mean, I don't know, Elliot, you may be able to comment on this, but the CDC and everybody else recommended that one mustn't go beyond the 3-week interval, at least, for that particular vaccine. We know that the AstraZeneca, there was a time interval and there was efficacy measures on that. But how do you tackle that, in terms of your colleagues and people that you work with?
Right. Well, I mean, I'll let other people speak too, because I think that there's much work that's being done. But I will say that I think this issue of transparency, being very clear about not only what we know, but what we don't know, because there are things we don't know. You're talking about time limits and what won't work long term and how long the immunity is going to last. Being very clear about that. Being very clear with my colleagues about my own experiences. Like, okay, I had some pain. I'm fully vaccinated now. I had some pain, but I also had lots of chills and didn't feel well. Being very clear about that. Are giving people time off, giving people time to talk about it more, giving people time to express their experiences. I think this is about hearing people out in a way that maybe we haven't in the past. So, but I'll let other people weigh in.
Well, I would just also mention, I mean, I do think that the public is learning a lot of science in the past 12 months or so regarding this pandemic that they never were maybe forced to pay as much attention to in the past. And so this like transparency. So what you're talking about, as you said, Bisola, is what do you know and what do you not know? And just be honest about it rather than try to dance around that issue. And the other thing I was going to mention is even just, and I don't know what the term is in Europe, maybe Miriam can tell us, but in the United States, we use the term emergency use authorization. And even that term has all sorts of, questions to it, because it's like if you're in a roadside emergency, then you don't necessarily do the right thing. You just do whatever comes to you in the moment. And that's the reflection that people have over the approvals of these vaccines is it's hard for them to believe that many people to believe this wasn't a rush job and that we actually paid attention to the science, despite all the assurances from Dr. Fauci and others. And I think that, and so that whole, like, how do you teach the public to become scientists, in the midst of this pandemic, I think is really a challenge.
Yeah, absolutely.
Yeah.
Miriam, sorry, carry on.
Yeah. So in EMA didn't do the emergency use license, so that is the advantage we are having, I think, on continental Europe in that it's conditionally approved, but it's licensed and it has a brand name, so that's I think important. So we don't have that hesitancy. I think at hindsight, what the public really found difficult to understand is, I think, why something that usually takes 10 years now takes 1 year. And I guess we could have communicated much better front about that. Things like warp speed, or, I think that it has also been a lot politicized. That didn't help, but it's all hindsight. So now I think we need to see how we can improve this. There is a lot of social media, I think, conspiracy theories that I'm getting across. And I think you noticed that in the UK with the infertility and the recent BBC also news around that. I think it's in communities, and it's difficult now to reach those communities because it's like a self-fulfilling prophecy. They just link forward, and there is, because of all the search strategies, you don't get anything objective anymore, I think. So it's almost, you need to be part of that community to say something about this, and it's very difficult to actually penetrate, I think, and to get or to supply some materials or communication that actually counters the questions that they have. But I'm not a communication expert, but this is what I'm seeing and what I'm getting asked from the journalists, because they're constantly these questions. And recently we had this movie in the Netherlands from Andrew Wakefield with a virologist that was a Dutch well-known professor in virology, and they appeared together in a long video, and they were just making the claims that this was doing autoimmune diseases, etc. And it looked very true because they had pictures of scientific articles. You know, it was like a 20-minute long movie, I think. And if you are not a scientist, you couldn't say that this wasn't correct. So it's this type of materials that is being spread, and it was looked at by, I think, 2 million people in the Netherlands. So it's really difficult then to counter that. So yeah, I think that's the reality in which we live, and how to mitigate that, or how to, you know, how to address it. I mean, I look at Bisola.
Oh, you know, what you just said resonated with me. So, you know, this idea of what do you do to combat something? It's sort of the way that this has been handled is in a reactive mode. Okay, and I think that's part of the problem. You know, in terms of building vaccine confidence, and this is beyond COVID-19 vaccines, because we see very disturbing, you know, flu uptake, you know, HPV, pneumococcal vaccination. This is a problem, right? So we need to be more proactive. And I know that the CDC is working on that. But I mean, it's almost like we need to be aggressively proactive in terms of getting the information out there. Personally, I have not seen enough of that. And I'm imploring us, you know, as people who speak to these issues to advocate for there to be more information that's out there, as opposed to being reactive to the disinformation that's out there. In terms of some of this disinformation, to be honest with you, I'm not sure that we can combat some of that. I mean, people create some of these quote unquote conspiracy theories. Some of them are created for, you know, the sort of misinformation, strategic ways of like being underhanded and malfeasance and that sort of thing. But a lot of times people are creating these quote unquote conspiracy theories because they have no understanding or way to process things that are happening in their world. Okay, that's like a normal human thing. You try to create something to explain something to you, yourself, your social network. If you had the information up front, if this was more of a proactive approach, I think maybe we would see less of that in those people who are thinking through or believing in some of those quote unquote conspiracy theories. But that's one group of individuals. I would also say that there are a lot of people out there who are just waiting this out. There are a lot of people who are just taking a wait and see approach. They just want to see how this rolls out over the next few months, and many of them will likely be vaccinated. So I think, you know, maybe we just give them some time, and that's human nature again. We're in the middle of a pandemic. People want to see what the safety data shows. People want to see what data comes out. But in the meantime, yes, I do think that we need to be more proactive in our ways of addressing this issue.
That's great. Thank you.
Oh,
carry on. Sorry.
Just to build upon Bisola's comment, I mean, first, the waves of uncertainty that our most vulnerable patients have faced from the beginning of the pandemic, where they've lost maybe their livelihood, for example, or health insurance. And so speaking to the population about mRNA vaccines is a disconnect, versus vaccines will prevent you from dying from this novel virus. The vaccines are built to prevent you from needing to be hospitalized. And that is the moment of people then saying, okay, I believe science could do that because it may have helped my family with respect to polio, for example, or smallpox. And that message, getting that all of these vaccines prevent you from death and severe hospitalization and severe death, is a very powerful message. But we led with the platform, the unique platform, because it's maybe of interest to us as scientists and physicians, and how novel it was, even though it wasn't novel in of itself. There was 10 years of science behind that. And so I'm just acknowledging this is actually, whom are we talking to? What does that person need to manage in the midst of the uncertainty when their livelihoods have been affected? And I think that is where kind of the approach today, we want to protect you from dying from COVID. Any of the vaccines will protect you from dying from COVID. And I agree with Bisola's point, and we've seen that with the nursing home workforce in the United States. When the vaccine was offered at their place of workplace, 35% of our nursing workforce received the vaccine. But that population is now going to their local CVS or going to a mass vaccination center. So we have to give people a chance to understand the vaccine itself, talk about it with their neighbor, their clergy, their colleagues, their family members, and think of it as a range of vaccine confidence. And it's understandable considering all the effects of the pandemic beyond their own health and wellness.
And I think that's a point very well made. Sorry, Elliot, carry on.
No, I was just going to say, and avoid, any kind of statements of, of course you should do this. Of course you should agree this is a good thing. I think those kind of, we love to make those statements among ourselves and in our literature, our scientific literature. But when you're talking to the public, you have to just validate their concerns, even if you think they're not valid in your own mind.
And how much do you think does social media have a role to play in this? I know, Bisola, you brought this up in terms of the sort of misinformation that's going out there on social media. How do we tackle that?
I mean, social media feels like it's a juggernaut. It just grows out. It's out of control, really, the information that's out there. This is what makes us different from previous instances or episodes of emergency, or when we sort of need information. I'm not sure that there's a consistent, clear way to manage it, except for, I think I provided one slide where certainly we report disinformation, but disinformation gets out. I get it on my Facebook feeds about different things. The infertility issue has repeatedly popped up amongst people within my own social network. So it is what it is, but I think it's constantly, and this is, in my clinic today, constantly, listening and acknowledging that it makes sense to have questions, to be scared, just as Elliot just said, but at the same time, then, kind of reflecting on what it is that people need to know, what it is we know, what it is we don't know. I don't think that we stop social media, and I think freedom of speech, people should be able to express their anxiety. I think Rebecca mentioned a lot of this is coming from anxiety within humans, saying, well, I don't know what's going on, so maybe this will hurt me in some adverse way, so therefore I'm going to talk about it like that. And then that then spreads and whatnot. A lot of it, I do believe, has to do with our social and political context. If you have a leadership that has a calming force, if there's already some sense of trust in what's going on in your world, I think that will breed a better sense of confidence in whatever happens, whether it be vaccines or anything else that we tell people. But I just want to emphasize that we need to give people time. And I know we're all scared as scientists. We're worried about the variants. We're trying to get people to double mask, I guess, but we need to give people time. I do strongly believe that with time, with more information that's out there, with more comfort seeing people, being vaccinated, people will be more comfortable. And I think we're going to be in an okay space. There are going to be extremists who will never get vaccinated. We need to understand that, but there's a spectrum. Okay, so we're looking at the people who are on the fence, and we're trying to focus in on them. I think giving them time will be well worth it.
Sanjay, along those lines, I noticed in the earlier session 3, which was primarily a much more virology kind of oriented session, but there was the question in the Q&A about vaccine mandates, and I do think it. I would be surprised if anyone on this panel would agree that vaccines should be mandated, sort of going along with what Bisay just said regarding giving it time. But there is discussion, and I can say I know of a large HIV clinic that in the United States that wanted to mandate vaccination among all of their workers, really for the sake of the HIV infected patient population that they were serving. And it was like, wow, way too early to be saying something like that. So, but I'd be curious about what the others think. That's okay.
So Elliot, this is a question that's come up nationally as well, and it kind of slightly relates to vaccine passports in a very similar sort of way. That will be the way to kind of open up our economy. People will have vaccine passports. So I suppose the big question that we haven't answered yet, and I'd be really interested to know what this bit of the panel thinks, is that we haven't answered the question about whether vaccines stop transmission or not. And I think that's a key question before we start thinking about mandatory vaccination to protect others as a way forward. I don't know what the others think.
Well, it's silent. So what I think indeed, I mean, there needs to be more evidence on the transmissions. I mean, some evidence is becoming available and it does show to be positive. I think we need to look at countries that have like high vaccination rates. So Israel, so for example, what is happening there? I mean, we could learn a lot from the occurrence of COVID and what is happening. So I think that's really important. And then to mandate or not, I'm living in a liberal country, so it's in the Netherlands where I'm coming from. I mean, that's just not what they would want to do. And I also think that it would be really difficult to do that, and it would create a lot of antibodies in that sense, like to force people or to oblige people. So I, for myself, I think there is evidence from the literature that there is, at the end, if you have good educational programs and you talk to them and you listen, you reach more than you would just make it obligatory. So it's a forceful step that I'm not sure we are in the right stage to do that now.
Yeah, I completely agree. I don't know if anybody else has comments on this, but yeah, we certainly would not be going in that direction in the UK.
So I guess, I totally agree about the mandates. It doesn't make sense. I think it just breeds more problems, honestly. But as far as the passports are concerned, I'd love to hear other people's opinions on this panel. But as you think about that, you say it increases access and makes things open and people will feel like they can have more mobility. But for who? It's for the people who have access to the vaccine. So then you're creating more inequity because you have all these people who don't have access, who are struggling to access, who can't, have these passports. And it seems to be it seems to be counterintuitive to the fact that we know that with this particular pandemic and with others, there are these clear issues of disparities, clear issues of inequity. So then let's make it worse, by giving out passports and allowing some people to be able to do some things. And those people who can jump the line, if you want to call it that, I'm not going to make that kind of judgment statement, but I'm saying people who have access, and then other people who don't. So that just seems very unfair to me. But maybe I'm looking at it. I'm a health equities researcher, so maybe that's the lens I'm looking at. I would love to hear other people's perspectives on whether or not that might make sense in some circumstances.
I personally have not heard of anyone suggesting it at a point where access to the vaccine was still limited. So like where we are today in the United States, I mean, this would be like what I guess President Biden said yesterday would be July or August, where everyone who wanted the vaccine would be able to get the vaccine. I think that might be the point where people would be considering passports. I think the question really, I guess if we do have better data on transmission and suggest that it does, do a good job of blocking transmission, then I think the question might be like, if I walked into a crowded theater and I've been vaccinated, and do I care if all the rest of the audience has been vaccinated? Or do I feel I'm protected enough to where I don't have to worry about what choices the other people in the movie audience made? I think that would be an interesting scenario that maybe we can get to the science to support that, but we don't have that science right now.
Yeah, I agree. And I think that's what we're going to need to have very strong science supporting this if this is going to be a way forward. But like we're saying that there is emerging data that community transmissions are reducing, but I think it's a mixture of vaccination and all the other measures. So it's important that we don't forget the other measures, which unfortunately, this happened to me in the lift just the other day. Somebody walked into the lift and they didn't have their mask on, and I said, "Would you mind putting your mask on, please?" She said, "No, I've been vaccinated. I'm okay." Okay.
I'll just add a dimension of this is to not build systems and structures that are about COVID in the midst of a pandemic. And, going back to Bisola's earlier remarks, that it's the structures we've created within the systems that have perpetuated inequity. So before we build a new service like a vaccine passport, what do we need to go back through? What does it mean to be share documentation as a patient to a provider? What does it mean for other preventative health services versus building for this moment? And that's where I hope if we take on that lens, how do we ensure the structures and systems promote preventative care, promote engagement, add trustworthiness, we'll design better versus design with speed, and we'll perpetuate these structures that have led us to the disparities that are so revealed today.
Absolutely, and that kind of sums up this discussion really well. I think our time is running out, so I'd like to, at this stage, say a huge thank you to this panel. Fantastic talks, fantastic discussion. There's lots of chat in the Q&A, and I wasn't able to kind of answer all everybody's questions, but there's loads of ongoing discussions. So with that, I'll say thank you all to everybody, and we'll try and bring this to a close now. So for the audience, I think it's important that you put in the post-event survey, which will be sent out by email after this session, because that's the way we'll get feedback and improve our meetings for the next time. So if you're able to do that, that would be really great. A certificate of attendance will be sent to you upon completion of this survey, so please do that as well. The full recording of this workshop will be available on this virtual platform until the 10th of March. And use the same credentials to log in to rewatch the live stream. It will be available until the 10th of March. And then with that, I'd like to say a good night, a good evening, a good afternoon to everybody that's joined us. Please don't forget our next COVID-19 clinical forum is on the 23rd of March, and there are others after that. So please visit the website and have a pleasant evening, afternoon, night. Thank you all very much. Good night.